Well, hello, Nikki. How are you?
Good. How are you doing?
Doing very well. And once again, thank you for taking the time to join us today.
No problem.
Yes. And we're so pleased to welcome Dr. Nicole, aka Nikki Legro, to Rare Awareness Radio. And I think we have to probably take a minute to also thank Jill Hawkins, former guest on this program, who connected you and I together, which is always
hmm
nice to get a referral and always nice
hmm
to keep it in the family and in the community. So, Jill, when you listen to this, thank you for connecting us together.
Yeah, definitely.
And you've had a busy day already, as you told me.
Mhm.
So I really appreciate you coming on and taking some time to chat with us. Nikki, I'm sure a lot of folks are curious about, you as a physician, and it's to me, it's always a very interesting conversation when one person kind of talks about why they chose to pursue a career in medicine or in healthcare for that matter. And you've got sort of this additional focus that you've done on rare diseases, specifically the work that you've done through the Undiagnosed Disease Network, or UDN. Maybe you could just tell us a little bit what inspired you to begin with as it pertained to a career in medicine.
Yeah, I think growing up, my dad was an OBGYN, but he was
Okay.
a research doctor. So,
Okay. Didn't
um,
practice and so much. Yeah.
yeah, he practiced, but mainly his focus was on women's health research,
Hmm.
and he traveled a lot for that. And he took me and my three siblings on all of these conferences all over the world. And
That's pretty
from
cool.
that, yeah, so like in high school, I like, went to like Thailand and like Malaysia and all these places.
Wow.
From that, I was exposed early to just, being around a group of people who are like intensely passionate about helping
Hmm.
women.
Right.
And I saw how that interest could lead to like, just this fervor and passion throughout your whole life. But really for me, like when I was in high school, it was my AP bio class that
Uh,
really like inspired me. And
mhm.
actually we had one of our teachers came in and told the story of how they had a child with Tay-Sachs that
Okay.
unfortunately passed
Yep.
away really close to delivery. And they talked about what that was like to receive that diagnosis and having the next child and all the anxiety that came with it.
Mm.
And so I can like trace that back to like a moment in time where I was like, oh my goodness, like that must have just felt like so isolating and like
Sure.
so much anxiety and all of that. So like I had always had that story in the back of my head.
Right.
And then I went to college and I thought about doing PhD and I thought about working in industry, which seemed really cool with all the genetic technology and all the stuff going
Sure.
on.
Yeah. Especially as it evolves so quickly.
Exactly. But then I was always drawn back to medicine, drawn back to
Mm.
helping people.
Mm.
And then when I was in med school, it was kind of like a balance of like, what specialty do you want to do? And I found that like I love taking care of women and delivering babies and just witnessing human reproduction and growth.
It's pretty
And so
remarkable. Yeah.
yeah, it's awesome.
Yeah.
But then when that can go differently for some people, where they
Sure.
might have a unique genetic diagnosis either in themselves or their baby,
Right.
that was really where I like felt my calling was to help people. So people like the Hawkins family or
Right.
otherwise.
And that's a really beautiful segue. But before I say that, it's so interesting. My mom was a nurse, right? And
Mhm.
it was a huge influence on my decision to pursue a career in healthcare, right? So
Yeah.
I think so much of it starts with our parents. And then it was once I started working in hospitals and working, one-on-one with patients that you kind of get a little bit bitten by that bug, right, Nikki?
Yeah.
It's
Yeah.
kind of hard to turn back from that. So a great
Exactly.
segue there, though. We mentioned Jill and we thanked Jill at the top of the show, but you became involved with Jill and her family and the FAM177A1 case, right, through the aforementioned Undiagnosed Disease Network. Can you tell us a little bit about that story, how that kind of evolved, Nikki?
Yeah. So I in my undergrad, I had worked in a yeast genetics lab.
Mhm.
And while yeast genetics is very fun and interesting, it is a little bit remote from humans sometimes. So after I graduated from college, I traveled for a while, and then I came back and I was like, okay, I need to get a job and I need to get into med school.
Right.
And so I applied to all these labs at NIH, and eventually was placed with Undiagnosed Diseases program, which is a nationwide program with multiple sites, but it was started at NIH by Dr. Bill Gall.
Mhm.
And I worked directly with him. And throughout that year, I just worked on like many cases in the translational lab where we tried to basically prove that the gene that came up in their sequencing led to, you know, a cellular disturbance and then led to the phenotype that we were seeing in this family or whatever.
Mhm.
And then from there, I had established some mentors and stuff like that. And I asked them to like help me get connected with the NIH site at Stanford. And then from there, went my first year of medical school, I spent in Palo Alto studying at Stanford. And when I got there, it was like kind of like a little like branch of the NIH Undiagnosed Diseases program where it was like a little
within
like,
Stanford School of Medicine.
yeah.
Okay.
It was like a little microcosm of like just, you know, like a smaller group of people, whereas like
Mhm.
the NIH was like the big production. And there I worked with the genetic counselors and like their team of doctors, and I was given like multiple cases to work on, and I basically reviewed medical records and extracted like data from them. And I worked on a few different families cases where we basically got all the data from them, trying to put together like what is this unique rare disease defined by, like do they have different facial features and all that.
Right.
And then for Jill, for the Hawkins family in particular, they had just, I think, re-reviewed the her family's genes and like decided that, or like were highly suspicious that FAM177A1 was the
Mhm.
causative like variant. And so for that, I like basically reviewed, I don't know if Jill knows this, I think I told Jill, but I like reviewed like thousands of her children's records,
Yeah.
like literally from her like little like pediatrician on outside of Seattle. And like all of their geneticist records, all of their ED visits and all of that we had
Wow.
access to.
That's a lot to go through.
Yeah, exactly. Yeah. And basically we just put together like their medical life story. And the purpose of that was to write this report in this publication,
Right.
to convey to other researchers about this new disease.
And in terms of your publication, which was in Genetics and Medicine, right, Nikki, if
Mhm.
I'm correct, obviously you were the co-lead author on that. I know there was a lot of significance associated with that research and kind of what it revealed about the disorder. How do you feel kind of looking back on that today?
Well, that whole thing was, I mean, just like literally years of work.
Yeah, yeah. I mean, what a culmination. Yeah, yeah.
Yes. So when we started that in 2019, when I was at Stanford, with my co-author Jennifer Kohler, like literally in this span of time, she's like gotten married and had a child, and like I'm in third year residency.
Major life events happening over the span of this particular publication.
Yeah.
Yeah.
So, but back to 2019 when we had just like decided we were gonna, you know, work on it. I like left that summer because I had to go back to med school in Hershey, Pennsylvania. And it was funny because when I was there, they always like kept getting confused about where I was from. I was like, I go to Penn State Med School, but they kept being like, UPenn. I was like, no, it's Penn State. But
Lions, not Quakers.
Yeah. But when I left, I was like, oh, I can continue, like I can help work on this, like if
Right.
you can, because we were like just starting to like get some traction. And they were like, yeah, that's great. And then like over the next, you know, like few months and stuff is when we identified more cases. And by identifying them, I mean like from the genetic network, it's kind of like a match.com, but for genetics, where you can like upload your clinicians and kind of like match their patients, which had been my co-first author's Jennifer's like purview.
Okay.
She was a genetic counselor. And so then we got all in touch with all these other different families. And then a researcher in London who knew of a few other families in the Middle East.
Wow.
But over the 2 years that we worked on this, there was a few, like, I guess roadblocks, I'll say, with like, and like challenges, research challenges, I guess.
Sure.
Because for these publications, you want to have as many patients or individuals in these studies to prove and to show distinctly what this phenotype is. Because, you know, if you have like one family, you want to see it like repeated in multiple families, like a specific finding.
Sure.
And so like over the 2 years, we had identified like up to, I think it was like 10 other individuals, and some like, and this was also like 5 different families. But however, with the London cohort and the Middle East cohort, there was too many international like regulatory board
kind of blocking you and causing you challenges.
And so that was really unfortunate, because it would have been a much stronger study had we all worked together, and the collaborators in London were, you know, very on board with that, but ultimately we had to go with our like own US cohort.
Right.
And then there was also a family we couldn't get consent from because we like didn't have an address for them and stuff like that. So that kind of was also another challenge. But ultimately we like decided to move forward and worked on that for another 2.5 years.
Wow. It's such when you and I talked about this a little bit when we had your pre-call a couple of weeks back, and I was amazed at the duration. I mean, I am and I'm not, right? Because I do know how sometimes these different studies take, but just that different of, you were in different physical places during the course of this, right? Different points of your own academic and medical career. So it's pretty outstanding that you were able to get it all the way through to the end.
And with that, like the whole I think application and submission process and all of that, I think one of the things, especially for, I guess, families of rare diseases, to understand that like why they don't see more in the literature and there's not more like publicity and stuff like that, is because it is so, the peer review process is so thorough and painstaking. So for us, like we had done, I actually look back at the drafts, and we had submitted our paper in July 2023 and really did not get a decision until May 2024.
So almost a year. 11 months. And
that was after like several rounds of like really extensive edits.
Right. Wow. Well, congratulations on that. I know it was a long labor to do that. You know, we've talked about Jill a couple times, and you know, Jill and others like her have tried to become really powerful advocates for, you know, for the rare disease community in general, but specifically in the purposes of our conversation with FAM177A1. As you've collaborated with advocates like Jill and supported sort of these nonprofit research funds, what are some of the, you know, sort of unique advantages you see when you get to work as closely with a family like this who's affected by a rare disease, Nikki?
Well, I think at least for like over the last 4 years, it was like very, very motivating. I mean, it's like the reason why we're all doing this is so that we can relate it back to individuals and families. And I like just remember, like, you know, I would come home from like 80-hour work weeks of like residency, and then open my laptop and like start working on this. And like the few days before it was due, Jen and I were like on a call, and we were just like working on until like midnight or something. And so I knew like how much at least this one mattered to the Hawkins family. I mean, I don't think they all matter as directly to patients and their family, but I knew that like other people were counting on us. So that was very, very motivating.
Yeah, I can imagine. And that sense of community too, right? As well, I'm sure was very motivating. But just what you said about anybody who even watches medical dramas on TV knows that residents are crazy overworked, overburdened, but then to continue to put the time and effort into this, I'm sure that feels very rewarding as you look back on it now. And I'm sure the Hawkins family appreciates it greatly as well. And the work that, like the FAM177A1 research fund, Have you continued to collaborate with that research fund now, Nikki, post that, or where are you in that journey right now?
So I after we finished that publication, I've actually told Jill that I was more into like looking at more rare disease things. So I got
Yep.
in contact with Nord.
Oh yeah, sure. Yep, Nord.
Yeah,
Yep.
so I've been working with their group a little bit more. And then the American Society of Human Genetics also has like an advocacy thing,
Oh, that's cool.
which yeah, which has been really cool because like I told Jill, I've really like been able to springboard from doing like the basic research,
Right.
all
As
that.
a basic research scientist. Yeah, very cool.
Yeah, and to do like a little bit more advocacy.
That's great. That's great. Now, speaking of kind of, what you're doing now and next, correct me if I'm wrong, you are in your final year of your residency.
Third of
Third,
four.
okay, second to final year of your residency. You're at Georgetown. And you mentioned, you're kind of springboarding, but do you see yourself continuing in this space, Nikki, as really what you want to focus on?
Yeah, so
Yeah.
I want to I'm going to apply to fellowship for maternal-fetal medicine and genetics. And so these are the specialists that do prenatal ultrasounds, and then they can do the special diagnostic stuff for genetic diagnosis in pregnancy. And they can also care for women who have genetic diagnosis themselves. So for example, someone with osteogenesis imperfecta, like what does a vaginal delivery look like for them?
Sure.
And stuff like that. So I'm still working with that. And there's actually been really interesting and new stuff on that in like this world and realm. And at UCSF, actually, they do have been starting to look at doing gene therapy in utero for some of these rare enzyme deficiency disorders. And so that's like kind of like the next steps.
Well, that's very cool. I think maybe we talked about this before. My first cousin is a PhD at UCSF.
Oh, I didn't know that. Actually.
Yeah, she focuses on postpartum depression. That's her area of research. Yeah, very, very small world. Speaking of genetic testing, I mean, I'm a dad, and I can remember when my wife was expecting, and we were expecting, being offered genetic testing. There's still a lot of stigma kind of associated with that, Nikki, right? There's also the notion of, will your insurance company pay for it? Will they not pay for it? Where do you see some of that kind of evolving? And I think maybe more of the stigma associated with it, I guess, is what is the kind of heart of my question.
Well, especially one of the things that's evolving, speaking of stigma, is in our field, we have these like guidelines and stuff to test for like Jewish diseases or like Jewish genetic diseases. And what exactly does that mean?
Right.
Like these are diseases that affect everyone.
Right.
And so the shift in focus has been more to look at genetic testing for everyone because it's called like pan-ethnic carrier screening. So just basically looking for carrier screening and then genetic testing that applies to everyone. Because I think when we profile people like that, I think people would feel a little bit hurt if they do have one of these diseases and don't identify with that background and then feel excluded from testing. And then I think so right now ACOG recommends genetic screening for 5 conditions in pregnancy. And with the new genetic technology and everything, I really think that people are going to be able to choose to test for as much as they want during pregnancy. Which could be a good thing or bad thing.
Yeah, I guess every person is going to approach that differently, right? To your point. And then obviously insurance companies and what they're willing to pay for is, you and I both know things have to become sort of standards of clinical practice that are usually well proven over a long period of time before insurance companies will be willing to pay for those things. But it's good to hear you say that like the American College of Obstetrician and Gynecology recognizes these 5, and that's usually a very strong advocacy, right? For payers to start to foot the bill, right? Yeah, absolutely. And if you were to think about yourself 3 years ago as an early resident or an early career professional and the rare disease community, is it through research, you think, Nikki? Is it through patient care? Where are the areas that you would sort of maybe wish you focused on more or less? or the sort of advice you might give to someone who's interested in rare disease, either through research or patient care? I'm sure it's a balance, right, of both, but I'm curious on your perspective, again, looking back over the last 3 years.
I don't know. I feel like if I were to like give advice to like a first year
Yeah.
OBGYN residency or like resident, like
Yeah.
even when I applied to OBGYN residency, like one of the interviewers I talked to, they were like, how does genetics have to do with OBGYN? Like, they were like, what? And I was like, okay. But I think like as like a first year like resident, like when you're taking in so much information, all of that.
Yeah, it's so much. Yeah.
Yeah. Is just understanding that like when rare diseases affect everyone, and like although one rare disease might be like, you know, like long chain fatty acid deficiency and stuff like that, and it like might affect like, you know, 1 in a million. If you actually group all of the rare diseases together, like over 6,000, like they're actually more common than you think.
Really?
I think like applying that psychology to everything is, you know, helpful.
A pretty helpful way to think about it. Yeah. Yeah. And do you have any first years that come to you and ask you for advice, or are particularly interested in what you're doing?
Well, MFM genetics, I should say, is so niche. So I feel like it's such like, I mean, there's only a few fellowship programs. I think only like 10 graduates a year in the US in this specific MFM genetics. So that would be like specialists in prenatal genetic diagnosis and stuff like that. So yeah, I mean, most people are like, OBGYN in general is like mainly focused on like labor and delivery and like female gynecologic problems, stuff like that.
Health of the mom. Yeah.
Exactly. But I think genetics is going to play such a huge role in all of these diseases. Like we're going to learn so much more about like pelvic floor disorders and fibroids and all of this stuff, and because they're so heritable. So
I think about moms who have a really hard time with conception and carry, and how much of that potentially is linked to some sort of genetic, you know, a condition or rooted in something related to genetics, right?
Exactly. And there's so much unexplained infertility that and then another thing is with the pre-implantation. So let's say you do IVF and you have your embryos. When they do the pre-implantation genetic testing, they can only take a few cells. It really doesn't test for that much. Like they're not doing like a huge panel on them. They test for like, you know, conditions of interest that you're like, oh, I have a family history of Huntington's.
Of this, right? Or
or like trisomy 21, Down syndrome, which we know of. But this area is, I feel like, going to expand so much in the next few years.
Speaking of that, I mean, there's so much novel analysis, right, Nikki, and the dreaded AI, and all these things that you can do around sort of these novel AI platforms. Have you started to interact with those yourself? Where do you kind of see those playing a role in either research or even potentially impact on patient care?
Yes, AI. Well, I feel like you would know so much more about like its interaction with like medical charts and stuff like that.
Sure.
And we've seen it like with the use of like clinical tools, how it can record, you know, a doctor's interaction with a patient and then generate a note. But in terms of genetics, I'm probably not like the most skilled person to talk about, but I don't think that people understand, like in general, like laymen's and like even doctors, even like literally physicians, when you do a genetic test, like let's say you do whole genome genetic sequencing, you're going to get thousands of hits that you don't know what they mean.
Right.
So you're going to get thousands of anomalies or like variants. And like, this is all, it's kind of like a startup company now, like the last 10 years where we just like have these like websites like I was talking about, like match.com, where, you know, I'm going to put this variant on, and like if you have it and you're normal, then it's probably not pathogenic. And that's basically how it's been going. So like I feel like AI is such a good way of taking all of this piecemeal stuff and making it high throughput. And then just in terms of like clinically, I feel like it's going to make so many more things like that we do less labor intensive. So for example, like the anatomy ultrasound takes one person to do like an hour-long visit where they look at every single thing in the body on the baby.
Yeah.
Stuff like that. So you have to find all these structures. Well, what if we had, we'll do one ultrasound sweep and this way and that way, and then we give it to an AI and they can say, we found this structure, this structure, this structure, this structure.
Right. Because it has all the surface areas already pre-mapped, and yeah, that'd be pretty exciting, wouldn't it? Yeah. Moving away from the tech side for a second, Nikki, so many of the folks that we speak to on this program kind of talk about community and the collaboration and the advocacy, and certainly the important work that you're doing around research. And so often, because these are rare conditions or yet to be discovered conditions, it's challenging, right, to find individuals like yourself who are doing this on a wide scale or to get the attention of big pharma. What are some of the things that you kind of need? What are some of the things you think need to happen, Nikki, to kind of get more awareness and raise more awareness into is it more collaboration and advocacy? Is it more research? But then, of course, the research needs to be funded. I guess if I'm asking if you could wave that magic wand, like what would you most hope for?
Well, I guess I can talk about this from like two perspectives. And one is like from like a public health standpoint, and one is from like the medical field and medical training. So for example, to do most geneticists they'll do pediatrics and then genetics, and then they'll like focus on rare disorders, and what they do in the clinic is like spend like lots of time gathering history and doing genetic tests. This is not reimbursed well in the medical world.
Sure.
It's actually like if you subspecialize in genetics, someone could correct me, but I'm pretty sure you make less money than if you had not subspecialized. And then,
which is not a great incentive.
Yeah. And then also, so MD PhDs, this is like a 6-year program where you can go right from med school and you can get 2 degrees. There's actually a really high concentration of geneticists that come out of those programs of MD PhDs. So there's a lot of really, really smart people. But that does not necessarily translate to like public health and awareness, because it's not really like glamorous career.
Right. Yeah. There are things that are a little bit more, to your point, either glamorous or get the attention, right, of whether it's mainstream news or media or anything else, right?
But I think like if I like look back at like the last 5 years, what's been really interesting and like what's covered by like New York Times and stuff is, for example, the N of 1 Batten's disease. I don't know if you saw that publicity. So when they do kind of like far-reaching projects to help one person, that is very interesting for people. And I also think I don't know, we talked about this the last time about, I forget what but the government has basically incentivized drug companies trying to make up treatments for very rare diseases. So they've like taken a lot of the regulations and stuff like that. And I think everyone like in the public health and what's very like flashy is like experimental and like novel therapies. And so when that comes on the market, people start to learn more about those diseases. For example, SMA. And the reason why it's flashy is because the treatment costs $1 million a year.
Right. And that's the sensational thing that mainstream media grabs onto, to your point, right? Yeah. Well, we've got a guest coming up in the near future who will be speaking with us about Batten disease. So stay tuned for that, I guess. Kind of that focus and the broader cause of Batten disease, if you will. Nikki, you've gotten through a lot in the last couple of years, and I'm sure there are many parts of it that are rewarding, and maybe it's easy to say that the most rewarding thing was, your key publication in genetics and medicine. But I'm going to let you tell us what the most rewarding thing was, as you kind of personally reflect to where you are today.
I guess like in terms of that publication and that work, like when I got the email that our like paper had been accepted, I was just like so it just felt so validating, I guess. So that, like, from a research standpoint was really good, and that was really, really highly motivating.
Mm.
And then in terms of like residency, I guess, and becoming a like young doctor and learning those skills, one of the most recent rewarding things was, like, I'm in my third or fourth year, so our second 2 years is where we kind of teach the younger residents.
Okay. Yep.
Is like I've been able to like chief or like guide
Yep.
some younger doctors through things. Like now, they come to like ask me things that like 2 years ago I was like, did
You were
not
asking.
know.
Yeah. Yeah. That's pretty cool. Yep. Yeah.
I just remember like going to my first like vaginal delivery. I was like, there's so much blood.
Yeah.
Everywhere.
Yeah.
So,
that's pretty scary. Yeah. I've been in the room when my daughter was born, and it's a pretty intense experience for sure. Yeah.
I mean, it's just so incredible to like see new life.
Oh God. Yeah. 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 It is the most amazing thing. Is there such a thing, Nikki? I'm curious, as you were just telling me about, your second, your third and fourth year versus your first and second year. Is there a typical day for you? And what does it kind of look like?
So the thing about residency that's fun is that we're always rotating. So like every 5 or 6 weeks, we're switching services. And so we mainly rotate within like divisions of obstetrics and gynecology. So we'll do labor and delivery days, nights, and then we'll do inpatient, where we'll take care of people affected by GYN cancers such as ovarian cancer. And then we'll do gynecologic surgery, which is like hysterectomies
and ENC, that kind of stuff.
Yep, exactly. And then we'll do the surgeries can be robotic or straight stick laparoscopy, minimally invasive, open, all of that. So
yeah, sure.
That's kind of like the great thing about OBGYN is that we're always doing stuff and it's always different, and we're always working with our hands and doing different procedures. And the best thing is we get to take care of women like completely. Like we don't have to refer them to another.
Right. You've got them for the whole duration. Yeah. Yeah.
Yeah.
Which is amazing.
So like, for example, this week I was in surgery on Monday. And that was actually the first time where I got to use the Da Vinci robot.
Oh, very cool.
So that was really cool. And then I was in clinic, and then I took this test, and then next week I'll do labor and delivery night shift.
Yeah. As a man, I can't relate to this at all, but I can speak from the experience of when my wife's OBGYN told my wife that she was moving to Toronto and could no longer be her doctor. My wife cried and cried. Like, this relationship that you establish with your patients, I think is quite remarkable and very, very unique in medicine, isn't it?
Yeah, definitely. And I had always admired that, like growing up with like my dad and stuff, like people would just give him the weirdest gifts because they just like it was like he one time like got this like hot pink shirt from a patient that was like Ricky's hot dogs, and I was like, what is this? What is happening? And then we always joke with like our family, because like we'll be like out with my dad, and like these random women will come up to him and be like, Dr. Legro, and my mom was like, who is that?
Who's that? Yeah.
So I mean, it's great. Like I don't know if I honestly don't know if there is a male equivalent, like a doctor that you would tell and everything to, and could take care of you throughout your whole life. But that's what's unique and great.
And I think that's, again, I talked about my wife's experience, but I think that's where that bond comes from. Right? Yeah. Plus anybody that kind of shepherds you through a simultaneously joyful and traumatic event that is childbirth.
God, it's trauma bonding.
Yeah, truly, right? That's so cool. Nikki Legro, thank you so much for coming on and talking about your sort of intersection of advocacy and research and clinical care and medicine and all the great work you've done and all the important implications that you've had on not just FAM177A1, but families affected by rare diseases. And the best of luck to you on your journey and your career. I know you're going to achieve many, many great things. But once again, we've been speaking with Dr. Nikki Legro, and we really appreciate your time today, Nikki.
Thank you so much.